I'm Taygan. I'm a third year medical student. I really chose to do this presentation because I feel like A, I think they're kind of fun to learn about, and B, it's really prevalent around this area. Just Joplin, just the four states area, because of socioeconomic factors. We have a lot of patients with diabetes that is not well controlled, and we have a lot of elderly people. So I feel like this was just something I'd like to bring awareness to. Okay. So just so you know, some of these images are going to be kind of graphic. They're non-healing wounds, so they're going to be a little bit gory. If you're not uncomfortable with that, I'm just letting you know right now. Okay, so just some epidemiology. So about 8 million people in the United States, about 2.5% of the US population, have the burden of chronic wounds. The majority of the chronic wounds are going to be found in the elderly. If they're not going to be found in the elderly, so under the age of 65, they're probably going to be diabetic patients that have poorly controlled blood sugars. Socioeconomic status really impacts your care. For example, a patient who is working a factory job and has chronic venous insufficiency, one of the things that is recommended for care and greatly impacts it is staying off your feet and elevating your legs. But if you rely on that factory job, you can't just take off and elevate your legs. The most you can do is come to wound care twice a week and put on your, 25 30 pounds of mercury or not pounds. Anyway, you need compressive socks to wear, but elevation of the legs to prevent that edema is a big thing. And wound care is expensive too. 28 to $96.8 billion are spent annually for Medicare. That's cost projections. It differs a lot because it depends on exactly what they're billing for. Sometimes that's going to be complications regarding wound care or without the wound care. And sometimes it's including the growth factor and the stem cell mediums that can be used, and those are really expensive. Okay, so as far as etiology, there are a whole bunch of different types of non-healing wounds, but they all share commonalities. First big one's gonna be inflammation. They're all gonna have, your IL-6, IL-1, all kinds of things like that. There's going to be a large amount of proteases, your serine proteases that come from your neutrophils, your collagenases, so your matrix metalloproteinases. You're going to have minimal growth factor activity. Your PDGF, FGF, all of those are going to be decreased. There's also going to be decreased proliferation of your cells within that tissue bed. Now, broadly, there's all kinds of different wounds, but you can kind of broadly separate them into categories of infectious, ischemic, metabolic, immunosuppressive, and radiation associated, which I kind of lumped those together a little bit in this presentation. So first one I'm going to be talking about is infection, and this is labeled as a separate category, but in all reality, if you are going to be having a chronic wound, the majority of people are going to end up with an infection in their chronic wound. The common pathogens are going to be Staph aureus, Enterococcus species, Pseudomonas, Acinetobacter species, Candida species, and Aspergillus species. Pseudomonas is the one I feel like that's seen most often. It has that, distinct, people say grape smell. I think it smells like rotten cantaloupe, but it has that biofilm production, and those biofilms are linked to wound chronicity. And that inhibits the proliferation. Your necrotic tissue that's going to go along with that is also going to prevent new tissue growth. It's also going to promote bacterial growth. It's going to be just this perfect little culture for more Pseudomonas or Staph or whatever is in there to continue to proliferate. It's nice and warm and moist, and it's dead, so there's nothing protecting it. And then retained foreign body ethnitis, shrapnel, or even just mesh from a procedure that can always cause chronic infections that are poorly healing. So as far as ischemia goes, there's pretty much three things underneath the umbrella of ischemia that are going to be the major ones. It's going to be arterial insufficiency, it's going to be venous hypertension, or it's going to be pressure injuries. So we're going to go over arterial insufficiency first. So this is a picture of wet gangrene. You can see it's a little bit weepy. It's very, it's a little wet. So arterial insufficiency is usually linked to atherosclerosis. You are going to have your arteries blocking your nutrients from entering those deprived areas. And so this is mostly going to happen because an initial wound is going to occur and then it can't heal. And so over time, it progresses into this very painful wound that is high morbidity. It's not great. Some characteristics of the wound, it's gonna be shiny. You're not gonna have any hair growth. It can be either pale or it can be black and necrotic like this. And it may either be dry or wet. And if you don't know what wet is, I'm sure most of you do. It's whenever there's a superimposed bacterial infection in that necrotic tissue. It's really painful. Some of the ways, if you can't already tell, whenever you're in wound care clinic, is you can do a ABI, an ankle brachial index, to check if it's over 0.9, in which case it will be pretty indicative of some arterial occlusion there. Or you can just do, I forget the name of the test, but you raise their legs to a certain level and hold it there, and claudication is going to occur. So the skin itself is going to turn pale and it's going to hurt them. So the next one is going to be venous. So this is something I feel like I've seen a lot more. I'm not super well versed in this, but you are going to have venous incompetency, usually the valves, or there's going to be a chronic DVT there that's going to impair outflow. Either way, it causes venous hypertension. First thing that's usually going to show up is going to be some hemosiderin staining from extravasation of your red blood cells into the extravascular space. It's going to cause that pretty characteristic staining down around the shins. It's called the Gautier area, and it's basically on the medial side of the lower leg, above the medial malleoli, which is most characteristically, as you can see right here, where you're going to start ulcer formation. You're also going to have usually going to have some lipodermatosclerosis from fibrinogen leaking into the extravascular space and just slowly sclerosing the surrounding area. As I said, it's associated with chronic DVT, varicose veins, chronic venous insufficiency. It's also painful, and it's weepy, unlike exudative. It's not usually dry like it is arterial, and it is painful, but it's not nearly painful as an arterial ulcer. Okay, so your third category under ischemia is going to be pressure ulcer. There's 4 different stages. Most of the time, they're going to be associated with immobility. So you're going to see it in nursing homes. You saw a big increase of it during COVID because of so many people under ventilators and not enough nurses or people to help rotate people properly. So first stage of a pressure ulcer is just going to be erythema. It just looks like a bruise. There's no skin loss. Your second stage of a pressure ulcer is going to be loss of skin through the superficial dermis. That's pretty painful. And so stage 3, a full thickness ulcer up to the subcutaneous fat. But honestly, and this right here is a stage 3 pressure ulcer on a patient's sacrum. But once you get to stage 4, which is full thickness involving muscle or bone, the patient's pain, it's going to be around the edges of the ulcer, but since they lack those somatic nerve endings that you do in the skin, it's not as painful, but it's a lot more serious, especially in the sacral area whenever patients need to defecate, and it's just dirtier down there, and it's harder to, it's a very big burden on a patient, and it's a big burden on the individual taking care of the patient. Okay, so under metabolic, there's two big ones. It's going to be diabetes and it's going to be malnutrition. Diabetes is going to be something that you're going to see a little bit more often just because malnutrition, it's just not as common in the United States. So diabetes is usually going to be associated with a foot ulcer. Most of the time it's going to be resulting from neuropathy or a combination of neuropathy and ischemia. And what I mean by that, it can be just an autonomic malfunction where you're going to be losing fine motor of like, you're going to have an autonomic dysfunction where you're going to shunt from arterial to venous with little time spent in the capillaries. It's that kind of neuropathy that's going to cause the ischemia, as well as you're going to have some microthrombotic occasions. You're going to have the perfect phenomenon for microthrombotic occlusions that will exacerbate this. You're also going to have loss of motor innervation from intrinsic muscles of the foot. It's going to cause the anterior tibial muscles to have too much pull, since those are the big muscles, and it's going to cause that claw foot deformity that you see in diabetics, and eventually Charcot foot. And that leads to the callus formation. It causes an abnormal load shift change, and so there's hold on. There's too much pressure being sent right here, and they can't feel anything, and so that's why those daily foot inspections for diabetics are so important, because the lack of awareness, I mean, they can't feel anything right here, and that's what leads to, their osteomyelitis, and then they have to get a met tarse foot amputation. So malnutrition also falls under metabolic. Pretty much, it's pretty simple. You need nutrients in your body to build wound healing factors. You need your fatty acids to make your arachidonic acid, to make your coursinoids, to make your leukotrienes and prostaglandins and all of those fun things. You need your proteins to make your enzymes and all of the other fun things that go in there. You need things like vitamin C to help, vitamin C and zinc to make collagen. And so if you're lacking in any of those, you're just not going to heal very well. And if you're severely lacking in them, as well as having a comorbidity like, I don't know, diabetes on top of that, I mean, you're in for a world of hurt. You're going to have a very hard time healing. As well as, I will also say, if you have those chronic wounds, you're going to have, you're probably also going to be in a malnutrient state, because your body takes up a lot of energy and a lot of nutrients to try and continually heal that and fail at it. And so it's an important thing to track the labs and the macronutrients and micronutrients of patients with chronic wounds, because that might be a factor in their care. So the last category is immunosuppression and radiation. So your immunosuppressives like corticosteroids, they're going to blunt the inflammatory phase of wound healing. So you're not going to have your margination of any of your white blood cells into the area. It means you're not going to have any of your PDGF or any of that, any fibroblasts inevitably coming in, causing the proliferative phase of wound healing. Radiation itself is going to cause breakages in the DNA with release of free radicals, which is going to further damage the surrounding tissue, especially in rapidly proliferating cells, which is going to be your epidermis. And radiation can also cause abnormal myotomal proliferation that's going to cause this fibrosis in the microvasculature that's going to lead to ischemia. So one of the most important things whenever you are interviewing a patient for a chronic wound, most of the time, if they have a chronic wound, it's going to be pretty obvious on a skin examination, but it's still important to get onset and duration, association. You want to know, especially if they're repeat patients who come and see you twice a week. You want to know if they have a change in the wound, and if you would really want to know if they haven't come in prior and you don't know how the change in the wound has been. You want to know past and current wound care regimen. You want to know severity of pain for pain control purposes, as well as it helps delineate the cause of the chronic wound. You want to know past medical history, past surgical history. Employment status is a big one, in my opinion, as well. So on physical examination, you are going to want to assess the wound, of course. Big thing, photography. You are going to take so many photographs in wound care. You're always going to have a centimeter ruler to measure the size, the dimensions of the wound. There's one thing to do is try and do a full skin examination if you can, especially in a diabetic individual. Since they can't feel anything, their lower extremities, you really want to take a really good look at it in between the toes. I mean, you want a very thorough exam with that. One thing that I've learned is that colonization of a chronic wound specifically, is not infection. And so someone who comes in with a venous ulcer, a chronic venous ulcer, and they have Pseudomonas on there, but they have no clinical signs of infection. They don't have fever. Their wound is not increased erythema or warmth. They don't have tenderness beyond the baseline tenderness that's already there, which is kind of difficult to know. They don't have any foul purulent drainage, no lymphangitis, those red lines running up the leg, and you don't have any swelling or induration at the site, which is also kind of difficult for those people who have that edema in their legs. But you can't just continually treat a colonized wound that's not infected, because they're going to get antibacterial resistance very easily, because you continually treat, and those bacteria, they're not going away. So the only way to get rid of that is to continually clean it. Something like a Dakin solution, which is sodium hypochlorite bleach, very, very weak bleach solution that's used. It doesn't damage the tissue. You're going to want to do a neurologic assessment again, especially on a diabetic individual. Your microfilament test, pain, all of those things. You're going to want to check reflexes in your patients. You're going to want a Berger's test, which is where you raise the leg to about 45 degrees and assess to see if there's any claudication of the wound, the paling, and the incredible pain from there. Especially if on one side it has that obvious arterial wound, but the other side doesn't necessarily have anything to the patient's knowledge. You want to check both sides always. I'd say to ABI, and you want to check your capillary return, again, especially on your diabetic patients. So on your lab studies, I mean, they're kind of a big thing, but they're not really the biggest thing. Wound care is really mostly a management thing. So, and this is going to depend on the patient. Your ESR, CRP, PCT, and white blood cell counts, they're all going to be elevated in a healthy patient. But if you have an elderly patient, their CRP will be elevated, but their white blood cell won't. And it's going to be the same for any other immune suppressed person. So labs aren't super duper reliable. In a diabetic patient with osteomyelitis, if you suspect that they have osteomyelitis, they may have a normal white blood cell count and PCT, but ESR and CRP. And you're probably going to want to go ahead and do a radiograph anyway, or else that's going to turn into a big problem, and they're probably going to lose their foot. For arterial insufficiency, you're probably going to do a Doppler study. It's probably going to be the same with the chronic venous insufficiency. And any cultured wound, you're going to want to, any infected wound, you're going to want to do culture on it. So that way you can narrow down the specific antibiotic that you want, or antibiotics. So you want to be conservative in medicine. So you're always going to try to do non-operative management first. First, you're going to address the underlying issue, any metabolic ischemia, etc. And all of your management is going to be depending upon what kind of chronic wound it is. So if it's a pressure ulcer, you're going to put the patient underneath a better repositioning schedule if they have already been one, or under repositioning schedule initially if they hadn't been on one. Physical therapy, you're going to treat any infection and optimize nutrition. So your stage 1 and 2 ulcers that aren't full thickness, through the dermis. You're going to do local wound protection and prevent progression, but you're not really going to do any true wound care. Now, 3 and 4, you are going to debride the wound and do local wound care. And especially if there's an eschar, which is the black tissue that you can't really see. It's hard to see the stage with an eschar. You're going to take that eschar off and you're going to continue to treat with wound care. Diabetic foot ulcers, they have a really high rate of reoccurrence. You're going to usually prescribe a diabetic foot boot, diabetic shoe for mechanical offloading, daily foot inspection. You're going to do also just your local wound care. So any debridement that needs to be there. Usually, I've seen a lot of people put, if insurance pays for it, stem cell or growth factors. Venous ulcers, again, leg elevation, elastic compression therapy, aspirin, and pentoxifylline. I haven't seen that a lot personally in practice. And then skin moisturizer for that dermatitis, eczema. And for arterial, you want revascularization therapy. That's the only thing that's going to be the definitive treatment for arterial ulcers. You need it before you need debridement. So revascularization is going to be the number one thing. You can't be conservative with that. That is the conservative treatment. And then, of course, you want to do your smoking cessation and lipid control to help prevent any further or future ulcers from forming from atherosclerosis. So you have your basic wound management. It can be, debridement itself can be sharp, irrigative, autolytic, enzymatic, or even maggot therapy, which is kind of interesting. So obviously your sharp is going to be your instruments. Irrigative is usually going to be 8 to 10 millimeters of mercury of pressure of something like saline. You can use tap water. It's not recommended against, but I mean, I don't really see why you would use tap water in a setting like that, or Dakin solution, saline or Dakin solution usually. Your autolytic, which is just going to be putting a dressing on it and letting the body do what it was. Enzymatic, so enzymes, and then your maggot therapy. So wound dressings are going to be very individualized on stage of healing, exudate produced, which is honestly one of the bigger ones, and other factors. Your gauze is just going to be infected, freshly debrided, or devitalized wounds. You're going to change them daily, twice, and moisten them with saline or Dakin solution because you don't want to pull off any granulation tissue that's going to form around those edges of the wound. That's no bueno. Impregnated gauze is just going to be occlusive that allows the wound to not be adhered to. It's also good for granulation, but you don't want to use it on anything less than just a little exudative wound. Transparent films, they're self-adhesive. They're permeable to water and oxygen, but not any larger molecules, which is good for moderately to heavily exudative wounds, and it's also good to help keep bacteria out. You have your foam dressings, which are going to be hydrophilic inside, hydrophobic outside. And those are going to be ones that are really, I see them a lot, honestly, especially they use it on negative pressure vacuum therapy, where they put the wound vac on and they suck it out. They use it on pressure ulcers, burns, skin grafts, diabetic ulcers, venous ulcers. They're really absorbent, so you don't want to use it in an arterial ulcer. Alginates are similar to foam. They're just used from an algae substrate. Hydrocolloids, they're going to be moderate but not highly exudative wounds, and you don't want to use it on infected wounds. And they have the downside of having to be changed daily. Hydrogels are dry to low exudative wounds, so those are going to be the ones that you're going to want to use on an arterial wound. And here's just some examples of that, just some pictures of them so you can kind of see what they look like. They pretty much, I mean, they're not anything too impressive looking. They look like anything that you would ever see on a patient. So the other thing you're going to do is ensure nutritional support. Patients are going to be in a chronic catabolic state, and so you're going to want to make sure they're supplied properly with nutrients. Exudative fluid is protein rich, and so some patients might have some hypoalbuminemia, depending on how large the wound is, how long it's been there, and how well they're eating. Diabetic patients, you're going to want to do glycemic control. That's sugar is the enemy. You're trying to reduce that. Negative pressure wound therapy is amazing. I love it. It's the best thing ever. I'm not super familiar with hyperbaric oxygen chamber therapy. You can't use it on venous insufficiency patients. It's not effective therapy for them, but it does work wonders otherwise. That's pretty neat. And then you also have your topical stem cell or growth factor therapy. So your VEGF, or more commonly, it's going to be fibroblast growth factor, or PDGF. Growth factors. Growth factors are cheaper for insurance than stem cells. So most of the time they want to play for a growth factor, but stem cells typically work better. So if non-conservative fails, or if you have an arterial occlusion, then you go to operative management. There's several ways to do that, and more than what I've listed. You have your split thickness skin grafts, and so those are going to be the most common. You're going to find them on the large surface areas of the body, so like tops of the thigh, middle of the body. They're not going to be fully through the dermis. That's why they're split thickness. They're the most common due to low morbidity, but they have the downside of being pretty thin, and they don't leave a great cosmetic result. As you can see, it's not super wonderful, but the skin will reepithelialize from where you took it from, such as the upper thigh. Your full thickness skin grafts, so all the way through the dermis, no subcutaneous tissue, you do not want that there. They're going to be thicker, more durable, and you're going to have better cosmetic results, but you have to take a smaller amount, because that skin that you take it from, like the groin area, inner thigh, that's not going to reepithelialize because you've taken away the dermis. And it has higher morbidity, but it leaves great cosmetic results. Your flap reconstruction, I'll talk a little bit more about that on the next slide, because I have an image of it. And then revascularization, so just taking away that occlusion from wherever it may be. So your flap reconstruction is basically going to have something where you already have a blood supply to, and it keeps its blood supply. You just reroute it to the area that you want it. This is mastectomy. I couldn't find anywhere else for like leg or whatever. But they take this area of skin and move it from lower abdomen up to the breast tissue, and it's still being supplied by the superior epigastric artery instead of the traditional arteries of the breast. And it can stay revascularized. It has pretty good morbidity. It's pretty handy for the most part. These are my citations. And that is the end of my presentation.